I'm Holly from the Department of Radiation Oncology. First of all, when we actually do radiation therapy, we calculate the dose through the radiation therapy system. And before we deliver this dose directly to the patient, we use Phantom to perform quality control for each patient's specific quality control. So as a part of this, it's about the process of manufacturing chest phantoms for patient-specific quality control. In radiation therapy, during breast cancer surgery, during surgery, we call radiation therapy IORT, and as shown in the figure on the right, intrabeam with spherical applicators attached, 250 kV low-energy generators is used. Spherical applicators will be inserted into the incision immediately after removing any tumor bed in the operating room with intrabeam to treat the high-dose radiation beam once. In general, textbook radiation therapy methods perform the external radiation therapy after the treated area is healed. In the case of the external radiation therapy, after 25 to 28 split treatments for the entire breast, it will be treated 5 more times with electron boost, which will take a total of 6.5 weeks. On the other hand, in the case of IORT, it is completed in 30 minutes because it proceeds directly from the operating room, and it can be seen as advantageous in terms of patient precedence, and the risk of target missing can be prevented by performing actual tumor beds and inserting spherical applicators. In addition, recent multinational clinical studies have reported that IORT does not lower overall survival rate compared to EBRT. Despite these advantages, there are several limitations. First, IORT does not have a pre-treatment planning system. Therefore, it is not possible to determine the distribution of doses in advance, and the volume of tumor removed in this way may vary every time depending on the surge pain. So there is no such IORT-only delivery QA phantom. In actual clinic, in order to measure the dose of the skin, one of the radiation-prone areas of breast cancer IORT, a dose meter called OSLD, is attached 4 pieces to left, right, up, down of the center of the applicator as shown in the figure to measure the dose. After in vivo dosimetry is performed, and then OSLD is read after treatment to determine the complication through whether the dose value has succeeded 1/5. However, since this procedure can also be seen after the actual treatment, it can be seen that it is not a way to prevent complications before treatment. In this study, we tried to manufacture 3D printed chest phantom with an anatomy structure similar to that of an actual patient to perform actual patient-specific DQA and confirm its usefulness. Next is the process of creating 3D printed patient-specific chest phantom. First, open the patient CT image to zone the soft tissue and lung. It is calculated with the average value of the Hounsfield unit included in this soft tissue, and lung also calculates the average value. When performing the corresponding 3D printer with the calculated average value in this way, it is determined how to do the infill ratio, and the parameters of the infill ratio are found through the following graph. Therefore, when printing the case of lung, printing is performed by applying an infill ratio corresponding to the average HU. Next, the initial virtual object will be defined for which size to print, converted to STL file using the slicing program, followed after a 3D render using the Blender program, and define the mashed and design the empty spaces for actual spherical applicators, design for the vacant space, and design the space to put the film to calculate the dose mapping. Models divided into several sections will be created as follows, and printing will be done using the 3D printer of the plot filament and FDM time as designed. When you assemble printed models together, it can be manufactured the following 3D printed patient-specific chest phantom. Next is the process of creating a lookup table between the infill ratio and Hounsfield unit. A total of 10 rectangular samples, about 4 cm wide and 2 cm high, will be 3D printed at intervals of 10% to 100% for infill ratio and 10% difference unit for interval. As shown in the figure on the left, 3D printing 10 PLJ pieces are manufactured, and if the pieces are CT images, The infill ratio is 10% due to the vacancy, so you can see the empty spaces. And as the infill ratio more increases, the vacant spaces are disappeared and are filled fully to be 3D printing. Select the ROI for each piece and calculate the average value with the HU value of the voxels included in the ROI. So, as shown in the figure on the right, there is also a lookup table corresponding to the average HU value compared to the infill ratio, and those without the infill ratio are created into the following linear type graph through linear interpolation. Next is how to do segmentation soft tissue and lung on the CT image of patients, applying an algorithm called seed region growth on to the image processing side on the part corresponding to the background. We'll be able to remove the background part. Background ROI is defined and the image is inverted with the rest of the patient body except background. When it was inverted, the lung part appears white and the soft tissue appears in an inverted color. On the image, applying the non-local total variation algorithm can result in the lung part being preserved and the soft tissue part is smoothing. If the k-means clustering algorithm, a machine learning method, is applied by combining the background ROIs with each other, the soft tissue and lung parts can be divided. To present you more about the process, NLTV denoising work will be a way to combine the non-local operator of existing total variation denoising to improve the signal contrast between certain prominent patches and unwanted noise. Using this non-local operator, we will evaluate the similarity between the small patch containing the voxel we are currently updating and the adjacent non-local patch and give weights. Non-local total variation objective function is mathematically expressed by the following equation. In this equation, D will be the existing total variation. Wj will be the weight function. For the weight function, the underlined part will be the spatial encoded factor, and the right term will be the non-local operator. In the spatial encoded factor, the intensity value of voxel corresponding to the J-index called Pj is greater than 1 if the intensity value is greater than gamma. So the weighting value is lower to preserve, and if this Pj has a lower voxel than gamma, it increases the weighting value through minimizing for the smoothing effects. The right side is the non-local operator, and the Pj plus k will be the index of the patch that is currently being updated, and the pi plus k will be the index of the non-local patch around it. Finally, if the difference between the two is close to 0, weighting is given high and smoothed, and if the difference between the two is large, it may be regarded as the boundary part is included, so for this part it is preserving. When this method is applied, the lung parts become preserved, and the parts included in the soft tissue side result in a blurred smoothing effect. Next, the k-means clustering algorithm, a machine learning method, is applied to the filtered CT image. To apply the k-means clustering algorithm, define how many partitions to divide and set the k-value. In this research, a value of 3 was applied, and 3 clusters were created. The initial mean value of each cluster is randomly defined by comparing the HU value in each voxel with the average value in each cluster. Each voxel is incorporated into the closest cluster. The center value of the cluster is continuously updated by averaging the HU values of the incorporated voxels. Repeat steps to on to 3 until the center value does not change from the previous value, and then output the absolute value to separate soft tissue, lung and background. 3D printed chest phantom was manufactured and measured for 5 patients. The treatment duration time was calculated so that a 10 gray dose on the actual applicator surface could enter, and the EBT3 film that measures the dose distribution in the perpendicular and parallel directions to the beam axis was put in to actually measure the surface dose and depth dose. Next is the actual 3D printed chest phantom. We obtained CT imaging of the actual 3D printed chest phantom and compared the difference between the extracted HU and the actual measured HU. For the soft tissue, HU difference was minus 12 HU, 2 plus 19 HU, and minus 45 HU to minus 2 HU for lung. This difference should be included in plus minus 20 HU for soft tissue, within 1% dose change on the actual treatment plan, and lung should be included in plus minus 50 HU on the dose change in the actual treatment, within 1%. Therefore, we can confirm to meet such criteria. The following quantitatively evaluated how accurate the geometry between the actual 3D printed chest, phantom CT, and patient CT. As an evaluation metric, there is a dissimilarity coefficient value, which is a value of 1 if the two objects overlap exactly, and 0 if they do not overlap at all. Soft tissue showed a value of 0.97 or more, and lung showed a value of 0.96 or more. We got to know that it matched very well geometrically. Next, it will be the result of measuring surface dose and depth dose using ReBD3 film. On average, there was a minus 2.16% error difference between the irradiated dose of the spherical applicator's surfaces, and the standard was 3.91%. And the picture on the right is the depth dose curve, which shows a 75% reduction from the applicator surface to the 10 mm depth compared to the drug prescription dose. So, it can be seen that the low energy beam used by IORD falls sharply. When there is a 1 mm error in distance, the difference in dose is shown about 10%. The results shown earlier were published in the journal Frontiers in Oncology to prove the excellence, and were also applied in Korea under the name of patient-specific quality assurance using 3D printed chest phantom for intraoperative radiation therapy. And PCT was applied for non-local total variation denoising algorithm. In conclusion, this study produced a patient-specific 3D printed chest phantom to simulate the dose distribution related to IORD and proved its potential. The 3D printed chest phantom was used to predict depth dose from spherical applicators, and surface dose was also predicted. Therefore, this presentation will provide a new opportunity to advance IORD and incorporate the 3D printing technology, because not only this breath IORD, but also brain IORD and pancreatic IORD are undergoing treatment. Thank you.